Okay. I think thank you. What I'd like to do is to introduce today's presenter, who, as mentioned, will talk about common types of cancer. He's Dr. Glenn Bauman, and we're very lucky to have him. Also happen to personally know Glenn, and I know he's a great doctor and a great speaker. As you can see on the slide, he is a radiation oncologist. That means he treats people with cancer with radiotherapy. And his particular special area is in genitourinary as well as central nervous system neurology type of cancers. He is very prominent. He's a distinguished university professor. For those of you who aren't aware, this is basically the highest honor that the university can give to a scholar. And he formerly was the chair chief. That means the overall head, both at the University of Western University, as well as within the London hospital systems, the chief. As also mentioned there, he is an associate scientist with the Lawson Health Research Institute. So I could speak more about Glenn, both from his CV as well as from what I know about him personally. But I also know he's a modest man, and without further ado, what I think I'll do is I'll turn the virtual mic over to Dr. Bauman and let him talk to us. I believe the talk is roughly going to be somewhere between 30 and 40 minutes. Purposely, we're having it that way to enable there to be time for questions and answers. I believe on the screens that was showing initially, we had asked that people, if they have questions, you don't have to wait, just enter them in the queue function. There's at the bottom of your screen a Q&A tab that you can then enter your question. At the end of the talk, I'll read out the questions, so there'll be an opportunity for Dr. Bauman to answer them. And before we start, if people can use the chat function, which is another little box at the bottom, a little button, just to let us know where you're from. This is, even though it's a program being put on by Wellspring London, it's been opened up by wellspring.ca across the country. And so we may, in fact, have people from across the country, and we were curious as to know as to where you're from. So just in the chat box, let us know what city or town or province or whatever you want to let us know you're from. And we'll be very interested in that information. Okay, then without further ado, I'll turn it over to Glenn and let him talk to us about common types of cancer in men.
Okay, thanks, Jeff. Can you hear me okay?
Yeah, all good.
Okay, great. So I just put a few learning objectives for the talk and really just cover a little bit about basics of what cancer is. So we're talking, about the same thing, or we have a common knowledge base. A little bit about where cancer sits in relation to other health problems, and then talk about a few of the most common cancers that affect men, and then use those as examples as to where we're making advances in prevention, detection, and treatment. And then just a little bit at the end about what can you do to try and lower your risk of cancer or improve your outcomes if you get cancer. So basically, what is cancer? I made this up. There's all sorts of definitions, but basically to me, cancer is cells growing when they shouldn't and where they shouldn't. So basically unregulated cell growth and motility. And I think it's important to kind of understand or reflect on the fact that this is not always a bad thing. And when we start out and when we are first, an egg and then get fertilized in an embryo, we are just a collection of undifferentiated cells. And somehow we have to get from this state to the state of being a fully formed person with all sorts of tissues and organs and things like that. So in order to get from here to there, you have to have, among this population of cells, a lot of plasticity, the ability to morph into different types of cells that are needed to make different components of the body. You need those cells to be able to migrate to where they need to go, and then you need them to grow to reconstitute the tissues and organs. So for example, in the early stages of embryonic development, there's something called the neural tube, which eventually forms the central nervous system, and it requires cells to differentiate into neural type cells and then to form itself into this neural structure that looks like a spinal cord, and then eventually forms itself into the brain as the embryo matures and as we become people, basically, as we become infants and are born. So this trend towards this plasticity, mobility, and growth towards stability, organization, and control. So regulation of these cell growth and motility, because once we're finished growing, we're always renewing our cells too. So there are very few cell populations in the body that are static. Most tissues renew themselves to some degrees, but in a highly controlled fashion. So these cells don't get out of control. So what happens in cancer is it's kind of the reverse. You go from, say, this histologic section of normal brain tissue that's sort of got a nice, regular, organized pattern to it, and through some series of events and some alteration in the programming of these cells and the environment in which the cells find them in, and other related cells, these normal cells can kind of revert back to this original state of having more independence, so to speak, than they should, and then they start to grow and move and change in ways that create a cancer, in this case a glioblastoma brain tumor. And you can see how disorganized and varied the appearance of this is compared to this. So that's and I guess what we are always trying to understand is what is the fundamental biology underlying this change. What are the genetic changes? What are the things that contribute to these genetic changes? How can we mitigate or reverse them, prevent them, to reduce the cancer problem? And that's a very simplified way to look at cancer. A more complicated way to look at cancer, but it's still a simplified model, is there's some very distinct hallmarks of cancer. These are basically behaviors or capabilities of cancer cells that most cancers seem to possess, and which seem to be enabled by different types of genetic changes. So you can see that cancer cells, where normal cells will grow to a point and then normally kind of self-destruct or apoptose as a form of control, these cancer cells won't do that. They have altered cellular metabolisms. They have different ways of metabolizing glucose and sort of make them more independent from normal metabolic controls. They permanently have a growth signal turned on and growth suppressor signals turned off. They have ways of evading the normal immune surveillance in the body, which would seek out and destroy cancerous cells. They can, again, divide basically forever without any end date, so to speak. They induce and are sustained by inflammation in the tissues in which they reside. They can stimulate their own blood vessel formation, so they get the nutrients they need. They can metastasize, they can get into blood vessels and travel to other parts of the body. And they have not only do they have genetic mutations themselves, but in acquiring these mutations, the whole genome becomes unstable. So it's kind of a sort of a positive feedback loop, that they acquire more and more changes that cause more and more of these features. And these cancer cells don't live in a vacuum. They form a tissue of their own, and they have a blood supply, and then they have other types of tissues that or cells that can enable or support their growth, like fibroblasts and immune cells and such. So they're very complex organs in and of themselves. So it creates real challenges in understanding how best to treat them, because of this complex biology and all of these redundant features that make them aggressive and dangerous. to use a very simple example, and this is an example of type of genetic change that happens in a couple of relatively rare cancers. One is chronic myelogenous leukemia. The other is called gastrointestinal stromal tumor. But what happens is that where you would have, so a chromosome contains all of your DNA all wrapped up very tightly. And it's through the chromosomes that the cells can access the programming they need to go about their business. But what happens in these tumors is that parts of these chromosomes get swapped, and part of the chromosome 9, it's called the able region, gets swapped with a part of chromosome 22 called BCR, and they kind of join each other together, and you get this abnormal fusion chromosome. And what it does is it produces a set of proteins that kind of step on the gas for the cell. It turns on all sorts of signaling pathways by turning on other types of proteins in the cell that then sort of signal downstream for those cells to grow and divide and do all sorts of bad things. So you can see this fusion protein here has an ability to take all sorts of other signaling proteins and turn them on by phosphorylating them, adding a phosphate to them, and that's what causes them to signal other parts of the cells or other pathways to work. But what's been particularly encouraging is that by understanding this biology, we've been able to, like we collectively as in the medical community, have been able to design drugs that are tailored to these proteins. So there's a drug called imatinib, which binds to this protein and prevents these other ones from getting in there. So you basically can turn off those signaling pathways. And this was quite revolutionary. I mean, this drug came on the market at the just, you know, in the turn of the century, in the 2000s, and this is just images. This is a PET scan which shows metabolism of the cancer, and all this black here is a type of cancer called this gastrointestinal stromal tumor, and here it is on a CT, and you can just see this is a very large tumor, and within days to weeks, treatment with imatinib just shuts down its metabolism immediately. You can see all of this, almost all of this black goes away. This is the bladder here that's supposed to be there, and then it disappears here, and the tumor has shrunk down, and then over the course of some months, it's regressed even further, and this is just an unheard of response for this type of tumor. And when this drug came on the scene, it was really hailed as a revolution, and this was made the cover of Time magazine. And so by understanding the cancer biology, it does definitely help us design new treatments. Part of the challenge with these types of drugs, however, is that because these cancer cells have a lot of redundant pathways, they can escape these sort of blockades. So these drugs can work really well for a time, but the cancer cells can often evolve and evade them over time. So they're truly an advance, but they are you know, and they definitely have found a place in cancer therapy, but they're not the magic bullet that maybe Time was saying. And more recently, you may have read about or heard about immunotherapy, and this is a very promising, and you know, so this is sort of the 2020 or 2020 version of Gleevec is immune therapies, and what they do is these are drugs that have found a way to basically prevent cancer cells from shutting down normal immune cells like a T cell, which would normally be able to kill off a cancer cell, but cancer cells have a special protein on their surface that tells the T cell to shut down. But now we have custom-made drugs that basically bind here and prevent the tumor cell from turning off the T cell, and then the immune system can now fight more effectively against the cancer. And you may have seen this in the news. This was just in the last couple of weeks, there was reports of these small clinical trial where basically a dozen people were treated with immunotherapy who had primary rectal cancer, and normally that type of cancer requires fairly intensive chemotherapy, often radiation and surgery, and can be quite can really affect people's lives, because people sometimes need a colostomy because of the location of the tumor and surgery that is needed to remove it. But this small trial looked at a special subset of people who had this mismatch repair deficit. So these were cancers that had a special defect that really produced a lot of genetic change in the cancer cells, and so much that it was easy for immune cells to recognize them as cancers. And when you used one of these drugs that basically unleashed the immune cells' ability to fight the cancer, they saw dramatic responses where on sort of, this is an endoscopic view, so looking through a telescope into the lower rectum, you can see this tumor disappears after 3 months, and it's still just gone after 6 months, and it's shrunk down on a CAT scan, and it's gone away on a PET scan. And then these people have basically been cured of their cancer by just this immune therapy. So these are the types of dramatic responses we're seeing with these new immune drugs. And again, to get this type of response, it's a small proportion of people who respond in this way, and the immunotherapy has definitely found a role in treating many difficult to treat cancers like melanoma and kidney cancer and such. But for most people, eventually the tumors find a way around it, and it can grow again. But I think this is just another really promising innovation in our cancer armamentarium. So that was just kind of a little preview of some of the exciting stuff that's been happening in terms of our ability to treat cancer. If we just step back again and think about cancer in general, one of the things I encounter in talking to people is there's sometimes a bit of confusion about how cancers are named and how cancers are staged. So, I mean, historically and traditionally, we've really thought about cancers as, where do they start? In what organ do they start? So a cancer that originates in the lung is called a lung cancer. And then when you look at that cancer under the microscope, it has a certain appearance, and we call that the histology. So we'll give it a more specific name, like non-small cell lung cancer. So that tells us something about the nature of the cancer, and sometimes they'll be graded in terms of how aggressive they look. And all of these gives us clues as to what to expect from in terms of the behavior of this cancer, how it might tend to spread, how it might, how likely it would be to come back after treatment and that and such. And then an important, so understanding the type of cancer and the grade and such is a very important piece of information. Then the other important piece of information is the stage. So how advanced is the cancer? How big is it? Where is it spread? So stage 1 cancers are cancers that are still at the site where they started and are on the smaller side. Stage 2 cancers generally are a little bit bigger, but still in the place where they started, or maybe they've gone to some lymph nodes nearby, but most often they're still confined to their original location. Stage 3 cancers may be bigger cancers located where they started, but commonly have also spread to some lymph nodes in the area. So lymph nodes are part of the immune surveillance system. The lymphatic system filters the tissue, the fluid that leaks out of the blood vessels into the tissues, and as it filters that fluid, it can capture cancer cells, and it can be a route of cancer spread. And then stage 4 cancer is cancer that's gone even beyond the lymph nodes and now has shown up in other parts of the body, like in the bone or the liver. And that can be through cancer cells accessing the blood vessels and traveling through the body in that way. So sometimes I talk to people and they say, oh, well, my father died of bone cancer. And then you talk to them a bit more and, oh, well, he had prostate cancer and then he had bone cancer. Well, that's a situation where almost certainly that his father had a prostate cancer that returned and metastasized to the bone, as opposed to a cancer that originated in the bone. So important to make that distinction between understanding, cancers can start in one organ, spread to other organs, but we still think of them as the cancer that started in that original organ. So when we think about the scope of the cancer problem, this information is all available on the Canadian Cancer Society website, and there's good slides and information about statistics there. But you can see that cancer is the leading is the leading cause of death among Canadians. Second, and sort of as a single entity, heart disease is sort of second. And then I guess if you were to group strokes and such with heart disease, maybe it's still under cancer, but blood vessel problems, and then other causes there, and there's a big bucket of other, but a very significant source of mortality. And now we have to put those numbers into context of our recent past, and with statistics that are available for cancer, they often lag by a couple of years. So we have to recognize that in the last 2 years, COVID has been a significant sort of contributed to mortality in Canada. Fortunately, not to the degree that it is in some other countries, but this is just data showing where COVID sits in relation to the other causes of death, and you can see that it's a significant component, but still much less than heart disease and cancer. I think important to recognize that when we think about mortality from COVID, this is direct, people dying of COVID. I think what we all recognize is that COVID has had a lot of other negative knockoff effects in terms of people accessing healthcare and maybe not seeking timely care for other health problems. And so there's probably a lot of collateral morbid health problems and death because of people being less able to or less inclined to seek early attention for other types of health problems. There's this question of whether we have an epidemic of cancer, and I think if you look at the red line here, I mean that the sort of this sort of number of deaths from cancer has been steadily going up, and if you just look at the absolute number of deaths, that is unquestionably there's more people dying from cancer in Canada. But this is an interesting graph in that if you kind of did the thought experiment and said, well, if we had the same sort of demographics and the same sort of population as we did in 1984, but we had the improvements in cancer care that we had over the years, you would have seen this reflected in a decreased number of cancer deaths. But because our population is growing in general, because of immigration, just natural population growth, babies and such, there's just more people around who can get cancer. But the biggest effect is that the demographics of our population in Canada are changing, as they are across the world, and that our people on average are getting older. And as your population becomes older, they're more at risk of getting cancer. So it's really this trend towards the aging of the population, which is driving the absolute increase in the number of cancers. So if you look at the relative death rates, correcting for the aging phenomenon, actually, people are doing better, surviving longer and doing better with cancer, but it's just being overwhelmed by the volume of folks out there who are at risk of getting cancer. So we start looking at cancer, the sort of mortality among men versus women, and this is a little bit different way of looking at it. This is potential years life loss. So this is so in some respects, I mean, everybody dies, so you would expect that the death rates should be this, total death rates should be the same. But if you're talking about premature deaths, where are the sources of that? And you can see that in terms of years life lost, relatively the same between men and women, but you can see that there's among men, accidents, heart disease, suicide, respiratory disease are also disproportionately affecting men and more life years lost, and so more men not living to their natural life expectancy. But again, cancer is still coming out on top, largely because, even though it's occurring in an older population in general, and maybe less life years at risk, but still such a common problem that it adds up to become the most significant source of potential years of life lost. So if you look again, now we're looking at, finally get to the topic, common cancers in men. So if you look at the most common cancers in men, so these are diagnosed cancers, not deaths from cancer. So prostate is the most common by far, and then lung, and then colorectal is in the top three. And that's where we're going to focus our attention tonight. I'm going to talk a little bit about testicular cancer because that is a uniquely male cancer, and it's also a bit of a good news story as well. But there's a lot of other types of cancers that affect men, but these are the three we're going to focus on. And so if we think about, well, where's the opportunity to do better? This is just looking at survival by cancer type, and you can see that for men with prostate cancer, survival overall is pretty good. So not many men are dying of prostate cancer. So maybe our focus there is, if we're doing okay and detecting and treating, we should maybe be thinking about, well, maybe are we treating, over treating men, or how do we minimize the morbidity of our treatments within a cancer like lung cancer? Our treatments aren't really working too well, and we know, what the main cause of cancer is in lung cancer. So maybe prevention should be our focus there. And then in colon cancer, we're kind of in between, but I think as we'll see, there's some opportunities in terms of early detection. And then we have some cancers where we just know where the opportunity is. So pancreatic cancer, for example, is a highly fatal cancer. It's kind of within I think it's right, number 10 is within the top 10, but we don't really have a line of sight to good prevention, good detection. Treatments are elusive. So it is a significant problem for us, and the focus of a lot of research within the cancer research community. So if we talk about lung cancer, I mean, I think people are probably pretty familiar. I mean, your lungs are in your chest. You've got two of them. The risk factors for lung cancer, no surprise there. The highest risk factor is smoking or secondhand smoke. And while there are other contributors to lung cancer, and those are relatively less prominent in terms of the other factors listed there. And there are people who are non-smokers who can get lung cancers. So maybe, something like 15 to 20% of lung cancers are among non-smokers. But what's interesting is among that group of people, those lung cancers are molecularly very different than smoking-related lung cancers, and they're actually more treatment options available to them because we can have drugs to target those molecular vulnerabilities. So, so we've talked about the different stages of lung cancer, and sort of in the upper right here is a PET scan of person with an early lung cancer, very small lung cancer. So that person could be treated with surgery or focused radiation and will do very well. But most people don't present with early cancers like that. They're presenting with stage 3 cancer, with spread to lymph nodes, or unfortunately with metastatic cancer. And while we have chemotherapy and immunotherapy treatments, when the cancer has advanced to these stages, people do not do nearly as well. And you can see that, for the very early cancers, this outcomes, survival rates are like 90%, but with each increase in stage, the survival rates drop dramatically. So unfortunately, most people are presenting with cancers around this end of the spectrum where there's treatments, but rarely are they curative. So quite rightly, society's focus for lung cancer has been on addressing the primary cause of lung cancer, which is smoking. So we have had all sorts of policies put in place at the sort of regulatory, governmental, societal level around how are cigarettes, sold, how are they marketed, taxes and such, and now the latest proposal is to put a warning on every cigarette, so poison in every puff on the cigarette. So I think anything one can do to drive smoking rates down is going to help, and one can see, in fact, that all of the collective efforts of individuals and governments and societies and such have driven smoking levels down over time. And when you look at the death rate from lung cancer, that's almost exactly the same slope in terms of decreased death rates from lung cancer, and that's directly attributable to decreased rates of smoking among men. So that is a good news story. And the beauty about quitting smoking is, or preventing smoking, is that not only do you address the second most common cancer in men, but also the most common cause of death of from cancer in men. There are at least 8 or more other cancers where smoking is known to be a risk factor. So even cancers that maybe are less intuitive, like colorectal cancer, smoking does increase your risk somewhat. But some of these other bladder cancer for sure, kidney cancer for sure. So you're having this beneficial effect across multiple cancer types, and reducing your risk of heart disease and stroke as well. So talk about high impact intervention. Preventing people from starting smoking or helping them quit is clearly where we're going to get the biggest bang for our buck. And when we're talking about lung cancer and health in general. We move on to colorectal cancer. So the digestive system, you've got your stomach, it empties into the small bowel, which then empties into the large bowel, which then into the rectum and such. Interestingly, cancers of the small bowel, even though there's a lot more small bowel in your gut, cancers of the small bowel is pretty rare. So when we talk about colorectal cancer, we'll talk about cancer of the large bowel, and that can happen anywhere along the colon. And there's a lot of different risk factors for getting colon cancer, including family history, whether you're getting polyps, but even there are lifestyle factors like how active you are, your weight, and then dietary factors as well. And the problem is that, unlike lung cancer, there's no kind of smoking gun here. There's no one factor you could say, well, if you just did this, your risk of colon cancer would go down dramatically. So the ability to work on the prevention side with colorectal cancer is kind of tough. We know that if you look across the world, there are societies where the risk of colon cancer is low, and that's largely related to the diet that is prevalent in that society. But usually that's quite a dramatically different diet, and to try and adjust the North American diet to get those same benefits is very, very, very difficult. So much as we'd like to work on the dietary side, and it's important to be mindful of the dietary side, it's not like stopping smoking for lung cancer. But you know, like lung cancer, we know that catching these cancers early is important. Again, like for most cancers, primary treatment is surgery, and then depending on the stage of the cancer, chemotherapy, and location of the cancer, maybe radiation may come into play. And again, we see this now as these are survival curves. So this is proportion of people alive and well years down the road after cancer treatment. So at the earliest stages, you know, people doing extremely well with stage 1 and 2. So cancers that are just on the inside of the bowel wall and haven't sort of gotten through the whole bowel wall. But as soon as cancers have advanced to where they've grown through the bowel wall, or when they're starting to get into lymph nodes or spread to other parts of the body, then the even though we have active treatments, as survival tends to drop off. But the sort of the opportunity in colorectal cancer is again related to biology, and we know that colorectal cancer tends to have a long period where they evolve, and colon cancer has kind of a predictable evolution from very small hyperplastic polyps to more larger polyps, to which are just benign growths on the almost like warts on the inside of your colon, and then you can get start to get some cancerous changes, and then into a full-blown cancer. And this, in most estimates would say this takes about 10 years to get from here to here. So you've got a long interval there where you can try and pick up that cancer at its earlier stages and treat it. So if you found these polyps when they're here, if you sort of scrape out those polyps, you can prevent that cancer process from developing. So early detection is the kind of opportunity in colorectal cancer. And so because of this, the province has and many jurisdictions in Canada and around the world have implemented early detection or screening programs for colorectal cancer. What these look like depends on where you are, but most commonly involves either doing stool tests periodically to look for signs of blood in the stool, which can be a sign of polyps and cancer, or more directly doing a colonoscopy from time to time to directly visualize the colon and deal with any polyps that might be detected. And within Ontario, we've had colorectal cancer screening in place since 2002, and there was a report published recently looking at the interval from 2002 to 2016, and what they found was that they were able to double the number of people being screened to 63%, which is quite a good increase compared to where they started, which was about a third of Ontarians. And then they saw that increase was reflected in 40% fewer deaths from colorectal cancer. So definitely an effective strategy for dealing with colon cancer. And so the recommendations at a provincial level are basically using the stool test every 2 years, though some doctors will recommend a colonoscopy every 10 years. And that's the strategy used in some jurisdictions. But I think this is definitely something where as men get older, over the age of 50, they should be talking to their family doctor about some type of screening for colorectal cancer. And again, you can see that this has been associated with a steady decrease in mortality over time. And I think when we talk about screening tests, it's important to recognize that screening is an intervention where you're looking for a problem in somebody who's not having a problem. So you want to make sure that people are going to have a net benefit. So for example, if depending on person's overall medical health and their medical background and their family history and such, and their age and such, it may be that in certain people, screening may cause more harm than good. So you have to be a little bit more nuanced sometimes in deciding whether to screen or not. And there are now more and more tools available online. This is just one example, which allows you to go in and put in some of your own personal data. It gives you sort of a readout whether you, on balance, would benefit from screening, or whether it may be you're more likely to not benefit, and maybe want to rethink the screening. So, so in terms of prostate cancer, again, we have our staging here with stage 1 cancers, very early cancers confined to the prostate. Stage 2, maybe a little bit more advanced within the prostate. Stage 3 starting to grow outside the prostate before metastasizing. And now we've got, in terms of risk factors, we don't have as many, and they're ones that we really, for the most part, can't influence, can't really change things that you basically are born with. So that, again, there's not an obvious prevention strategy here, though, because it's such a common cancer, it doesn't stop people from trying to figure out, is there some sort of effective prevention? Back in the 2000s, early 2000s, there was, from epidemiological evidence and some other studies, suggestion that vitamin E and selenium might be important micronutrients that could help prevent prostate cancer. So there's actually a study done, almost 35,000 men randomized between different combinations of these micronutrients, and unfortunately didn't show a benefit. But I think it illustrates an important point that even when we think that, well, what's the harm in taking, selenium or vitamin E? Well, here you can see that the vitamin E, slightly more cancers among the vitamin E. Now, was that truly the case, or is it just a statistical aberration? It's not 100% clear, but it does sort of imply that, some things might not be innocuous and could be working against you. Another area where people have been very interested is in lifestyle. So this was published just recently, and this was another sort of study where they followed a lot of men over a long period of time with really rigorous ways of assessing their health in terms of, were they at a healthy body weight, how physically active were they, what was their smoking history, what was their diet intake. And what was interesting in this study was that, having a healthy lifestyle did definitely confer benefits, but it didn't really prevent you from getting prostate cancer. But your chance of dying from prostate cancer was less. So if you got prostate cancer, you did better. So I think, certainly there's all sorts of reasons to adopt a healthy lifestyle in terms of benefits against other cancers and benefits in terms of heart health and things like that, and some benefits with prostate cancer, but that's not going to be our solution there. And in terms of, healthy diet, I think, often get asked in terms of what can men do, or what should men do after treatment for prostate cancer? And I always just advise them that a heart healthy diet is the thing that they can focus on, and Mediterranean diet is one example of a heart healthy diet. And I think all of these diets, emphasize, the importance of whole grains, fruits and vegetables, fatty fish, and then less of, processed foods and sugary foods and red meat and such. So now we're into this dilemma of detection, and again, unlike colorectal cancer, we don't have as good a detection paradigm or scheme as we would like. We do have a cancer with a long lead time, but we also have a cancer that, maybe we're at risk of finding cancers that don't need treatment, and our tools for detection are pretty inaccurate. So examining the prostate with a finger is not very accurate at picking up cancer in the prostate. This PSA blood test, which is easy to do, is not as specific as one would like, and a PSA may not be elevated in someone with cancer. It may be elevated in someone without cancer. So the sort of predictive value of a PSA is imperfect. And then to really confirm if people have prostate cancer or not, you have to do a biopsy of the prostate, which is invasive. And so again, this is where the current recommendations are around detection and screening are kind of ambivalent. And they say it really relies on a discussion with their family doctor about the pros and cons of even looking in the first place. And it's not for want of trying. I think there was a large prostate cancer screening study in the US that was negative, did not show any benefit to routine PSA measurements in men. This one was done in Europe, was a bit more rigorous, and maybe results are a little bit more representative of what you can achieve with screening. But even then, you still had to screen all 600 men to prevent one cancer death, and the benefits of screening really doesn't show up until at least 10 years after men enter the screening program. So again, and you do a lot of biopsies to find cancer, and all these biopsies potentially carry risk. So again, if you search online, there's a number of different calculators. This one lets you, it's interesting that there aren't that many calculators that tell you whether you should do a PSA. There's more calculators available to tell you whether you should do a biopsy once you know your PSA. But this one allows you to, based on your family history, your age, and what urinary symptoms you're having, gives you an estimate of what your underlying cancer risk is, which might help you in deciding whether you want to pursue that through your family doctor. And then it also has a calculator that uses the PSA value, if you have it done, to estimate your risk. And then it's just another example of a calculator. Once you have a PSA, okay, what's the risk of finding prostate cancer if you're going to do a biopsy? So if, for example, I just put in my age and just, I don't know what my PSA is actually. I haven't had it checked. I've chosen not to do that, but I just put in 2. And if, you're a man my age with a PSA of 2, chances are you're not going to have, 84% chance you won't have cancer there. And 14% that you'll find a low-grade cancer, one that probably doesn't need treatment, and only a 2% chance that there is a cancer there that needs treatment. And so that kind of brings us to this paradox in terms of prostate cancer treatment. And this was phrased by the famous urologist who said, is cure possible only when it's not necessary? So in these days, a lot of my urologic colleagues talk about pussycats and tigers, or tortoises and hares, in terms of acknowledging that some prostate cancers are very slow and won't grow or be life-threatening, where others will grow more quickly and can be life-threatening. So this was a study that randomized men between having surgery or no surgery, and among these slower growing cancers, you can see that you do decrease the number of prostate cancer deaths a bit compared to if you didn't have surgery, but most men are dying of other things other than prostate cancer. But then among more aggressive cancers, you can see that the benefit treatment is a little bit more pronounced, and fewer men dying of prostate cancer with treatment. And so there's actually a very large study done in the UK, and it actually compared, and mainly among men who probably have these slower growing cancers. When you look at the men they enrolled, it looked at men who were randomized. So they flipped a coin, and a third of the men were just monitored, and a third of the men had surgery, a third of the men had radiation. And you can see that with time, some of the men on the monitoring group did eventually require treatment. The other groups got treatment early on. But if you look up here, this line up here was how many men died of prostate cancer, and almost nobody did. And even among the men who had just active monitoring. So again, a trend these days towards prostate cancer treatment is not treating men who have these early cancers. And we know that all of our treatments can have effects on men's quality of life. So it can affect things like bowel function, urinary function, you know, hormonal function, like having menopause-like symptoms, sexual function, and all of these different types of treatments, and even active surveillance, active monitoring can have these effects. But what's interesting is that over time, our treatments have improved, and you know, if you look 5 years down the road, there's really not a lot of difference between quality of life between the 3 treatments. Though when you're talking about treating prostate cancer, it's like the cost of doing business, that sexual function is almost inevitably going to suffer. So just briefly, testicular cancer, uncommon. There are some risk factors, but again, it's not a cancer that lends itself to early detection or prevention. Most times men find it themselves by just finding a lump on their testes, and then treatment is primarily surgery with or without chemotherapy. Rarely radiation is used. But I think what's notable here is that testicular cancer was one of the first solid tumors, like tumors arising within an organ that has been able to be cured with drug treatments. And so Lance Armstrong is kind of the poster child for this. He had stage 4 testicular cancer and was treated with chemotherapy and cured. We think he's been cured, and he went on to win a number of Tour de France titles. Now, you know, that's not without its own controversy, but still being cured of stage 4 cancer and even competing in the Tour de France, I think is remarkable. And then you can see these survival curves. This is all for men with metastatic germ cell carcinoma. So you can see that there are lots of men who are doing really well with systemic therapy. There's still men who don't do well and where we still need to improve treatment, but still it's a remarkable success story. So just to wind up here, I mean, what can you do? I think, again, in terms of resources, the Movember website has a lot of great resources. It really focused on prostate cancer originally, but they've kind of expanded and now are thinking more about men's health in general. So there's a lot of great information there. And I think it's really interesting that they've really started to focus a lot on the social aspects and the need for men to, you know, open up more, to talk more, to spend time with people, the socialization aspects. And I think that really speaks to the, you know, issues around mental health and mental wellness for men, which have, you know, have been, I think, probably under recognized, and I think are really important aspects for us to address. And then again, their traditional focus on PSA, but also testicular cancer activity. I think they kind of, you know, top 5 things. I would also add, well, you don't smoke or quit smoking and have a heart healthy diet. So I think that's what I wanted to cover. Went a bit longer. Oh, you always go longer than you think, but we probably have time for a few questions still.